Well, it looks like we might be.
Sorry.
We might be hitting a quorum. Reza and I had feedback with each other. That's what we call it when we fight. um, so Jess, if you want to start whenever, I guess we can go. I'm recording it just so you know.
Okay. Sounds good.
Future presidential run.
Sounds good. All right. Well, welcome, guys. Thank you guys so much for coming. My name is Jessica. I am an ultrasound fellow with the Department of EM, and I am honored to talk to you guys about the basics of lung ultrasound. My goal is that by the end of this, hopefully this will be a tool that you guys can use clinically and that will really help you out in your patient care. Before we get started, though, I want to get a little bit of a sense from you guys. Have any of you guys used this clinically? Have any experience with this at all? I just want to know. You can respond yes or no in the chat. I just want to get an idea. Some in the ICU and home consults, Austin. Not too often. Cool. Okay. Awesome. So that's good. This is hopefully a newer application, but I think something that's clinically very applicable, particularly to you guys. So we'll talk a lot about that as we go. As I go, though, please feel free to interrupt at any point. Let me know if you have questions. You can type in the chat or unmute yourself. This is very informal. Just let me know if you have questions or need some clarification on things, okay? All right. So why should you guys care about lung ultrasound? You can get stat chest x-rays fairly rapidly. It gives you some information. However, stat chest x-rays are not immediate, particularly for you guys. I mean, I've rotated in the ICUs and a little bit on the floors, and if you have an acutely dyspneic patient, it sometimes takes a while, a lot longer than you want to. So the beauty of lung ultrasound is that it's something that you can do really quickly at the bedside and actually incorporate those findings into your patient care really rapidly. And so it's really helpful for the patient who is acutely short of breath. Additionally, I venture to guess that probably every single one of you has seen chest x-ray reads like this, where it's completely ambiguous what exactly is going on, because it's hard to tell on a chest x-ray if something's fluid versus a pneumonia or what it might be. And this is where lung ultrasound comes in, because it can help you kind of clarify what some sort of opacity on a chest x-ray is. And so there's a lot of benefit to ultrasound that goes beyond just a portable chest x-ray. So specifically, we're going to be talking about point of care ultrasound, or POCUS. And I'm making this clarification because I think it's important to understand the distinction between POCUS and comprehensive ultrasound. Because with POCUS, you are the actual operator, you're obtaining the images, and so it's important to know your limitations. Typically with this, you are answering specific yes or no questions about an organ, not necessarily getting a comprehensive assessment of the organ. So for example, with like biliary ultrasound, we're asking yes or no, is there evidence of cholecystitis or evidence of gallstones, but not, what the liver looks like and, venous flow and all those things. And so it's really important to understand that you're asking yes or no questions. And so with lung ultrasound, these are the specific yes or no questions that you're going to try and answer. So is there a pleural effusion? Yes or no? Is there a consolidation? Is there evidence of pulmonary edema? Or is there a pneumothorax? This is kind of the scope of what you are looking for with lung ultrasound. And these things alone give you a ton of information clinically when you have a patient who's short of breath. So just a little bit about the data behind lung ultrasound. I just wanted to hit on a couple of the kind of landmark articles with this. This was this particular study is a meta-analysis that looked at a lot of different studies looking at the diagnostic accuracy of chest x-ray, AP chest x-ray versus ultrasound for the diagnosis of pneumothorax. And across the board, they found that ultrasound was significantly more sensitive than chest x-ray in terms of diagnosing pneumothorax, with essentially equivalent specificity. Which I agree, those are impressive numbers. And it's important to understand the limitations of chest x-ray and that ultrasound could potentially be a little bit more beneficial. And similarly, there were studies looking at kind of how ultrasound does in terms of other diagnoses. So this is a super old study, but it was actually published by Dr. Lichtenstein, who is considered kind of a father of lung ultrasound. He's published a ton of literature about this. And this is one of the landmarks that he did. It was a prospective study, only including 32 patients. They were all ICU patients, and looked at the sensitivities and diagnostic accuracy of ultrasound versus chest x-ray versus auscultation and physical exam, and found that across the board, again, ultrasound had better sensitivity in terms of diagnosing pleural effusions, pneumonia, and pulmonary edema. And this kind of study has been replicated in 2011 as well with more numbers and still held true. So the take home from this is that in general, ultrasound is more sensitive in terms of making the diagnosis than chest x-ray. Awesome, I love that. So how does this apply to you guys in medicine? Also, shout out to your website. This is where I got this picture. I love it. How do you guys, how are you going to incorporate this as medicine residents? So this was kind of a cool study. This was a prospective study where they gave ION residents a handheld ultrasound machine and taught them how to perform lung ultrasound. And this is back in 2014 when handheld ultrasound machines were like super new and incredibly expensive. Now they're much more common with this. But what they did is they taught the residents how to perform lung ultrasound, and they asked them to provide a working diagnosis of acutely dyspneic patients before and then after they performed a lung ultrasound. And they compared how this correlated with the final diagnosis as determined by the attending physician. And they presented their numbers in terms of area under the curve, so closer to 1 is better. And they found a statistically significant improvement in the diagnostic accuracy when it comes to diagnosing pneumonia and pleural effusions, and then this sort of all causes, so just kind of across the board, which is super nice because it's something that's performed obviously by the residents themselves with a fairly limited amount of training. One important note, though, is they had a statistically significant decrease in the diagnostic accuracy in this kind of other cause, and specifically these were diagnoses of anemia, ascites, and dehydration. So this all goes to say that it doesn't totally replace your physical exam. If you have someone who has tense ascites and you're only ultrasounding the lungs, you should probably just take that into account. But overall, it certainly can help kind of increase your diagnostic accuracy with things. There are other studies from a medicine perspective that show that ultrasound in patients with heart failure can actually be used to predict patients' readmission rate in 6 months. Based on the amount of pulmonary edema that they have left on ultrasound, which is kind of a cool disposition thing with these patients. And then finally, there is a ton of literature emerging about how ultrasound is useful in COVID patients. Particularly from Italy, they do lung ultrasound a ton, and there is a lot of studies that are coming out that show that potentially it's useful for triaging these patients in terms of identifying who might be appropriate for discharge and kind of outpatient management, who is at risk for becoming hypoxic, or may need ICU admission. And they can kind of help triage these. There's some studies that show it's helpful as kind of a prognostic predictor. And then some data just suggests that it's helpful in determining who might benefit from proning and things like that. So the potential benefits of lung ultrasound are quite broad. And I would argue, particularly in the medicine realm, when you guys are on the wards and don't have access necessarily to a chest x-ray within a couple of minutes, it can give you a lot of data up front that can help you kind of target your therapies in a little bit more appropriate manner. All right, questions about some of the data behind it before we talk about how to perform this? All right, I'm going to take the silence as a no, but again, feel free to interrupt if you have questions. So now we're going to talk about how exactly this is done and what you're looking for with this. So first off, in terms of probe selection, this is one of the only studies that you can actually use any probe with this, and you'll get different information depending on the probe that you choose. So it's important to know a little bit about kind of what you are looking for and with which probe. So the phased array, this is the one that you're going to use in cardiac ultrasound and potentially intra-abdominal ultrasound. It is great for deeper structures. It can give you a lot of information about intraparenchymal pathology, pleural effusions in a normal sized patient, things like that. Same with the curvilinear probe. So this traditionally is a intra-abdominal probe. It's a lower frequency, but is able to penetrate deeper tissues. And so this is fantastic if you're looking for like pleural effusions in a more obese patient. You can find a lot of intraparenchymal pathology with this. So these two probes, the phased array and the curvilinear, are great for more intraparenchymal pathology. If you are looking specifically for pneumothorax, or you really want to get a good look at the pleural line, I probably recommend the linear probe. This is a higher frequency probe, but which means it has great resolution for the more superficial structures. So that's kind of the trade-off with all of these probes. When you're performing lung ultrasound, it's totally fine to switch probes as you go, depending on kind of what you're looking for with this. In terms of the technique for scanning, there are a lot of different algorithms that have been proposed as to how specifically you should perform this and what lung zones you should look in, how many rib spaces, and things like that. The take home from all of it is that the more rib spaces you scan, the more you're going to increase your sensitivity overall, because you're probably going to catch some of those smaller consolidations with that. Generally in the emergency department, we do a 10-zone scanning technique. So we do 2 zones anteriorly on each side, an upper lung and a lower lung, 2 zones laterally on each side. And then in addition, we do an area called the PLAPS point. This is something that was proposed by Dr. Lichtenstein, who I mentioned earlier, as kind of the highest yield point on lung ultrasound, because this is the most dependent area in the thorax. So exactly where it is, you kind of extend an imaginary line from basically the nipple line or the inframammary crease in females over to the posterior axillary line. And again, that's the most dependent point in the thorax. So this is where, in a supine patient, this is where small pleural effusions are going to accumulate. This is where B lines or pulmonary edema, you will see this here first before it kind of extends throughout the rest of the thorax. And most pneumonias actually have a component in this area as well. So it's a fairly high yield point that you definitely should include when you are scanning for lung ultrasound. In patients who can cooperate with you, it's great to actually scan posteriorly as well in order to detect things like a retrocardiac opacity or something like that. But there's plenty of patients, obviously, who can't necessarily sit up or participate with that kind of thing. So we don't always include it, but you can certainly increase your diagnostic accuracy if you scan posteriorly as well. So what are you looking for when you are performing this scan? The ideal view you want to get looks something like this. So this is a curvilinear probe, so you can tell by the footprint here, but it's going to look similar with any probe that you use. And ideally, you're going to do a longitudinal plane. So your indicator is going to be towards the patient's head, and you want to get 2 ribs within the view if you can. So here's a rib here, you can see, so kind of hyperechoic with shadowing behind it, that's bone. Here's another rib here, and then you see a pleural line right in between. The reason you're trying to get this view is because sometimes the pleural line can look similar to soft tissue, particularly people with like thicker chest walls. It can get a little bit confusing. So to really ensure that you're looking at pleural line itself, you want to try and get this particular view. So here's just the video here. You can see pleural line. There's a little kind of movement there. That is a normal scan. This is sometimes called the bat wing sign because you see a rib, pleural line, rib, and it's supposed to kind of look like a bat. I'm very good at drawing, in case you're wondering. So as you perform lung ultrasound, you can kind of think of yourself as Indiana Jones with this, because you are looking for artifacts. That's kind of what you're using to interpret the scan, okay? Specifically what those artifacts are, they're kind of an alphabet soup in terms of what their names are. So we'll go through the important ones with this. I do love dad jokes. So the first are A lines. A lines, does anybody know what A lines are? You can mute yourself and answer. All right. They come before B lines. Awesome. I love it. So A lines are these horizontal lines that extend kind of beyond the pleural line. So we'll just play this video. So here's pleural line here, and you see these hyperechoic horizontal lines kind of extending into the far field. These are due to some reverberation artifact from the ultrasound beams themselves, and they are indicative of normal lung. So A lines are a good thing. That's normal dry lung. B lines. So someone mentioned B lines. Does anyone want to describe kind of what these look like? No? Okay. So B lines are hyperechoic line, like vertical lines that extend from the pleural line into the far field. So typically if you are looking for intraparenchymal pathology with lung ultrasound, you want your depth set anywhere from like 10 to 15 centimeters is probably ideal with this. And B lines end up looking like these hyperechoic lines extending from here out to the far field. They often are described as looking like a flashlight appearance, kind of shining down from the pleural line. These are indicative of a fluid in the pulmonary tissue. The important thing with this is B lines in and of themselves don't mean pulmonary edema. It actually could be from fluid due to a consolidation or something like that. So B lines, while they do indicate fluid in the tissue, aren't necessarily pulmonary edema alone. We'll talk more about that a little bit later, okay? The last artifact that's important to know are Z lines. So these are, I'll show you an example here. These are little kind of what they're called comet tail artifacts that extend from the pleural line. They're small though, and they don't go to the far field. These are also indicative of normal lung, and again, they're described as comet tail artifact. You can kind of follow these in order to find if there's lung sliding present with that. All right, questions about sort of normal findings in the artifacts that you're looking for? Yes, so A lines are due to reverberation artifact. So basically you have ultrasound beams coming in, they kind of hit the alveoli and then they bounce back and forth through the alveoli in order to, and they cause these kind of reverberation lines, which are very normal. Only occurs if you have a dry lung. Whereas B lines, so there's a bunch of different kinds of B lines, they're all a little bit kind of different in terms of how they develop, but it is because of fluid. So the ultrasound beams travel well through fluid as opposed to air. And so you can actually see some kind of echogenicity with that, with B lines. Does that make sense? It's a lot of fancy ultrasound physics. All right, so moving on to some pathology. Starting first with pleural effusions. So in general, ultrasound beams, as I mentioned, likes to travel through liquid. So if you were to put a probe on someone's chest and you see a bunch of anechoic fluid, that's fairly obvious. You know that that's an effusion. It doesn't look like normal lung, right? The question, though, comes when you have small pleural effusions that are a little bit more subtle. And there are a couple of signs that you can use to help kind of determine whether or not there's a small effusion present. So the first is something called a spine sign. So normally, in a patient who doesn't have an effusion, you would not be able to see the spine shadow extending above the diaphragm. And the reason that is, so ultrasound beams, if they come through liver, ultrasound can travel great through soft tissue. So it can go and show you the spine down here, which is this like hyperechoic kind of lumpy bumpiness in the far field. Air, though, does not conduct the ultrasound beams well. It just sort of hits the air in the lungs and then scatters. So usually you shouldn't be able to see the spine anywhere above the diaphragm, okay? The moment you have a little bit of fluid in the thorax, though, some of those ultrasound beams can actually get through and show you the spine above the diaphragm. And that's indicative of an effusion. This is a good example just because it's a giant effusion that you can see here, and you see this, the spine extending above the diaphragm. But here's a little bit more subtle example. It's kind of hard maybe to determine if there's lung or fluid there, but you know it's fluid because the spine is extending above the diaphragm. So that's spine sign. The other thing that can suggest a pleural effusion is something called loss of the mirror sign, or the mirror image artifact. So this again is some fancy ultrasound physics, but what happens is in a normal lung that does not have a pleural effusion, you get some of the ultrasound beams causing a mirror image over the diaphragm. So basically this is liver here, this hyperechoic line, that's diaphragm, and this is actually lung up here. But it looks just like liver, and that's the mirror image. In contrast, if you have an effusion, this will go away. So you get loss of the mirror image sign, or the mirror sign. Now, one of the questions people often ask is, how do you know that this is a mirror image versus like lung consolidation? Because in consolidation, sometimes you get something called hepatization of the lung, which I'll show you a little bit more later, where lung actually looks like liver. And really the only way that you can differentiate is if you look for some of the like vascularity within the liver. So if I were to kind of determine that this was a mirror image sign, I would look to see that these vascular structures are mirrored over here. I liked this example because this patient has a little echogenic liver lesion right here that's mirrored up here. So you know that this is a mirror image sign. All right. Questions about effusions before we move to pneumonia? So talking about pneumonia, this is kind of one of the fun ones because you can detect pneumonia on ultrasound sometimes even sooner than you can on chest x-ray. And again, it's more sensitive than chest x-ray is for actual pneumonia consolidation. So in normal lung, I mentioned earlier that you have angle of the probe and how you're, yes, it does. So typically it's seen best in the plaques point actually that I mentioned earlier. And really the way the physics work behind it is the ultrasound likes to travel in kind of a straight line. So you have to get, it's kind of a specific view with this. You won't always see it, but if you don't see it, you should at least be concerned and look for secondary findings of pleural effusion, like the spine sign or something like that. Good point. So with moving on to pneumonia, so a normal lung has a pleural line that's very homogeneous. It's just kind of a straight line. There's really no lumps or bumps to it. That is a normal pleural line. One of the things that you can see with pneumonia is you'll start to see some lumpy bumpiness of that pleural line, which is suggesting kind of developing consolidation. And then you may get something called a subpleural consolidation, which basically is some kind of bumpiness of the pleural line and some kind of consolidated tissue right underneath the pleural line. So here's an example of that. You see this tissue coming into view here. That is not the straight pleural line that we saw earlier. So something is developing right here. This is kind of early consolidation or is associated with like viral pneumonias. The other thing that you see on this video is something called the shred sign, which is basically when your pleural line just looks like it's shredded. So it looks kind of like this. That's also suggestive of a developing consolidation in that area. Hepatization of the lungs. So this is something that's seen in lobar pneumonias, and basically it is exactly how it sounds, where the lung tissue starts to look like liver tissue. So here's liver on this side, here's diaphragm separating the two, and you can see this is sort of the same echo texture as the liver is. That's hepatization of the lung. And again, not to be confused with mirror image, so you really want to make sure that you're not seeing some of the kind of vascular structures here mirrored on this side. So those are kind of suggestive of pneumonia. The next thing, though, that help kind of increase your specificity in diagnosing pneumonia are bronchograms. And these get a little bit complicated, so I'm going to do my best to illustrate them for you. There are air bronchograms and fluid bronchograms. And within air bronchograms, there's static air bronchograms and dynamic air bronchograms. So let's take this kind of from the start with this. So you have your lungs, normal lungs full of air. You put an ultrasound probe on them, and normally your ultrasound beams, as I mentioned earlier, they hate air, they get scattered by air, so all you see is the pleural line. You really don't see anything deeper to the pleural line because the ultrasound beams are scattered because of the air. Once you have diseased lung, though, you have consolidated lung tissue, the beams now can travel actually through that tissue, so they can actually travel deep, and you can see some of the deeper structures like the bronchioles. If the bronchioles appear anechoic or black, what is anechoic on ultrasound? And by that I mean, is it air? Is it fluid? Is it bone? You guys know? Fluid, awesome. So fluid is anechoic on ultrasound. So if you were to look at like the IJ, for example, it's totally okay. It sometimes can be confusing. If you were to look at the IJ, blood is anechoic. It shows up as a dark circle. It's the same thing here. If you have fluid in those bronchioles, it's going to show up as anechoic. That is a fluid bronchogram, which means you have consolidated lung tissue. You're now able to see deeper into those structures, and you can see kind of anechoic bronchioles within that consolidated tissue, okay? Opposite being air bronchograms. So air actually shows up as echoic or white on ultrasound. So if you see white in the middle of consolidated lung tissue, that's an air bronchogram, all right? The difference between static air bronchograms and dynamic air bronchograms, I think, are a little bit more helpful to see with actual videos of this. So on this image, this is liver here, this is diaphragm right here, and this is consolidated lung tissue. And you can see these kind of hyperechoic white stuff kind of within that lung tissue. The static part means that they are not actually moving in and out with the patient's respirations. So you'll see kind of the diaphragm move with respirations, but those actual bronchograms, the white stuff here, those are not actually going to move in and out with the patient's respiration. So here's just the video of that. So these are the air bronchograms there. They're just kind of static with the patient's respiration. In contrast, dynamic air bronchograms are going to move in and out as the patient breathes. So this is actually all consolidated lung tissue. Kind of looks like liver. This is also hepatization of the lung tissue. Nasty looking pneumonia. And play the video. This is the best video I've seen of air bronchograms, so I stole it from someone else. So as the patient breathes, you can see those kind of white lines move in and out with respirations. This is absolutely pathognomonic of pneumonia. Reason being, what that means is there is air that's moving in and out of the bronchioles surrounded by consolidated tissue. So that's a lung that's ventilated, but just horribly consolidated. So when you see dynamic air bronchograms, they're not super common, but they're pathognomonic for pneumonia. All right. And then finally, this is just a picture of fluid bronchograms. So I mentioned that fluid is anechoic on ultrasound, so you can see kind of the just dark bronchioles highlighted within consolidated lung tissue. There's also a big effusion surrounding this as well. So that's the kind of anechoic fluid surrounding the lung tissue. Okay? Questions about any of that? It's kind of confusing. It took me forever to kind of figure out what these are. So do you need any clarification? Any questions about it? Ooh, good question. Do stable air bronchograms suggest anything specific? In general, they can either be atelectasis or pneumonia, because what it means is you have consolidated lung tissue with air in the bronchioles, but it's not actually necessarily moving. So it's not necessarily pneumonia. It could just be atelectasis. So if you see them, maybe suspect pneumonia, but you can't be 100% sure unless you see that the lung is actually ventilated with the dynamic air bronchogram. Does that make sense? Cool. Awesome. Any other questions about that? All right. We're going to move on to pulmonary edema. So pulmonary edema is characterized by B-lines. Typically, so B-lines are kind of cool because they correlate with the degree of pulmonary edema. In patients actually with pulmonary edema, you will see them fairly diffuse, often kind of starting from the bottom, but then going up to the anterior lung fields as well in more severe pulmonary edema. The really cool thing about this is that they are very quick to develop if you have someone who has like acute onset pulmonary edema, and they are quick to resolve with treatment. There was actually a study that looked at this. They did a lung ultrasound of dialysis patients before and after dialysis, and they could see the disappearance of the B-lines as the patient received dialysis and had the fluid removed, which is kind of cool. So you can actually use it to track patients' treatment and how they're doing with that, which is really neat. Nearly like 60% of normal people have one or two B-lines kind of just above the diaphragm on each side. That's normal. But anytime you have more than 3 B-lines per rib space, that's pathologic and suggests fluid within that tissue. The important thing with B-lines is to evaluate the distribution of them. So in pneumonia or consolidation, you can actually see B-lines because in those scenarios, you might have fluid in that tissue as well. But typically, that's not going to be diffuse. It's going to be kind of in a focal area. Pulmonary edema, though, tends to be much more diffuse, and you'll see B-lines kind of everywhere. So it's just important to pay attention to kind of the distribution of your B-lines. One thing, so the number of B-lines also correlates to the severity of pulmonary edema, which is kind of cool. And sometimes you can get some confluence of the B-lines. And you can actually get something that looks like this. This is called a Bureau variant. And it's basically just one giant B-line per rib space. And that's a severe pulmonary edema with that. One last kind of comment on B-lines. You can actually see them in trauma as well, and that usually suggests a pulmonary contusion. So again, they're not always strictly pathologic for pulmonary edema, they just suggest fluid in the lung tissue. And so the distribution of B-lines is the most important component with that. All right, moving on to pneumothorax. So pneumothorax, the kind of characteristic thing that you have to look for with this is you're gonna look closely at the pleural line because you're looking for lung sliding. This is where the linear is going to be helpful. You can tell that this is a linear probe because it's kind of straight across up here. And normal lung, you should see those little Z lines, the comet tail artifact, kind of moving back and forth. That is normal lung sliding. And again, it's just the comet tails kind of moving back and forth. That's normal lung sliding. Pneumothorax then is loss of lung sliding. So here's an example. This is the pleural line down here, and you don't see any of those Z lines. There's nothing moving back and forth. So this is a pneumothorax. It's not always totally apparent though, and so sometimes it's helpful to investigate this a little bit more. Anybody know what I'm referring to with this picture, aside from the fact that we probably all need a vacation? Yeah, the shore sign or the sandy beach sign. Awesome. So what that means is if you have any question about whether or not there's a pneumothorax present, you can investigate further with M-mode. So what M-mode does is it drops a kind of line down your image, and you can put that wherever you want. You put it right over the pleural line, and it looks at the ultrasound beams in that line over time. So the structures right here correspond to the soft tissue up here, and then the structures down here correspond to kind of the far field of the image, okay? If you have normal lung sliding, you will have movement of the pleural line, and so it creates this kind of sandy beach or like a seashore with this. That's normal. In contrast, you can see a barcode sign in pneumothorax. And what that means is you're just having, none of those tissues are moving because you don't have lung sliding. And so you're going to have the image actually just look like a barcode, okay? The last thing, this is actually pathognomonic for a pneumothorax, is something called a lung point. So what that is when you are catching on your ultrasound the area of ventilated lung and pneumothorax lung. And so you'll see normal lung sliding and a lack of sliding in the same image. So this is an example of that. You see lung sliding here, and then when the patient exhales, it goes away. Lung sliding, and then it goes away, and you have no lung sliding here, okay? That's a lung point, also indicative of a pneumothorax. All right, questions about that? The last thing that I just wanted to briefly touch on is what you'll see on ultrasound in COVID. So one of the characteristic features of COVID is that you have this kind of diffuse interstitial infiltrate, just kind of with terrible chest x-rays that kind of look like ARDS. And it's going to be the same thing on ultrasound where you have this diffuse kind of evidence of infiltrate. What that means, though, is you'll see scattered areas of consolidation and normal lung and maybe some B lines and things like that. So typically, pulmonary lung ultrasound in COVID will have just kind of random distributions of all of those things that I mentioned, whether it's subpleural consolidation or scattered B lines in different areas, accompanied by kind of normal lung in other areas. It's just kind of patchy all over, fairly consistent with COVID on that, okay? That is all I have in terms of the lecture part itself. Do you guys have any questions for me before we move on to the game? I'm going to stop sharing this part. All right, no questions? All right, does everybody have Kahoot downloaded? So if you guys have never played Kahoot before, the way that this works is I'm going to put the game board up here, that way you guys can all see it. And there will be a game code that you can enter in order to get on this particular game. It'll have you put your name in, which is important so we can see who the winner is of this. And then each question that I present will have several different answers, all of which are like color coded. And your individual, on your phone, your individual game app will have kind of color coded buttons that you can push that correspond to the answer. The most important part to know is that the amount of points that you get for each correct answer depends on how fast you answer the question. So each question starts at a maximum of 1,000 points, and then those potential points decrease as time increases. So the goal not only is to get the questions right, but to do it quickly, okay? All right, so let me share this. All right, there's your pin. I'm just gonna wait a little bit longer. We got 18 people on here. We'll see how many we got. All right. Anybody having trouble? We okay to get started? All right, you should be able to join as we're going, okay? I'm gonna go ahead and start the game. All right. Horizontal hyperechoic lines seen on lung ultrasound. Most people got it right. Those are A lines. So those are indicative of normal lung. The B lines, remember, those are the like flashlight looking lines. So the kind of vertical lines extending from the pleural space. All right. Nice work. It shows us the leaderboard each time, okay? No pressure. All right. I'm not going to read these to you because it gets confusing. So. Ooh, nice. All right, so static air bronchograms are pathognomonic for pneumonia. The answer is false. We talked a little bit earlier, so dynamic air bronchograms are, because that means you are having ventilated lung surrounded by consolidated lung tissue. Static air bronchograms just mean there's consolidated lung tissue that could just be from collapse or atelectasis of that. So static air bronchograms could be atelectasis versus actually a pneumonia. Awesome. Neil's still in the lead. All right, next question. All right, so that picture had a spine sign in it. So while you couldn't totally tell that there was an effusion there, there was a spine sign, which means that there is an effusion. A little bit confusing because it could have just been a consolidated lung. However, you could tell that there was diaphragm and spine extending above it. So that's why it wasn't a pneumonia. Nice work. Neil is crushing it. All right. Nice. So that picture showed B lines, and if you have them diffusely, that's pretty specific for pulmonary edema. So in that situation, you would obviously want to avoid IV fluids, not necessarily avoid antibiotics, but antibiotics aren't indicated on that alone. Instead, you should probably treat for pulmonary edema with BiPAP or whatever. Nice. All right. Oh, well, it's a good question. There's triangles and diamonds, okay? If you can't see the colors. Nice, everyone got this one right. So that was a picture of also B lines. So if you have B lines diffusely, also again, pulmonary edema, probably should avoid fluids if you can. Neil is on fire. All right. So that was the seashore sign. So it's important to pay attention to kind of the near field and the far field and see if they look similar. Pictures are a little bit hard, obviously, on this game, so no worries. But that was the seashore sign, which means it is normal lung sliding, whereas pneumothorax would have been the barcode. And typically, M mode is not actually helpful with pneumonia. Ooh, we got a new leader. All right. Nice. So linear transducer is going to be the best one specifically assessing for pneumothorax. So that is the high frequency probe that looks at the really at best at superficial structures. The rest of them are not bad. You can actually, well, endocavitary is probably not ideal, but curvilinear and phased array, you can see the pleural line. They just don't have the greatest resolution in the superficial structures. They're better for deep structures. All right, Drew's still in the lead. All right, so the answer is true. So mirror image is seen when your lungs are fully expanded and there is no pleural effusion. If you have loss of mirror image, that suggests pleural effusion. Good. Curious who Meow Meow is. Oh, sorry, guys. All right, you're correct. So this is a shred sign. Remember, that is when the pleural line is sort of shredded and it's not continuous and homogeneous. The one up here they were B lines. This one, these are A lines, and then this was a spine sign. Adriana. Awesome, nice job. So this is consolidated lung tissue right here. The red one, this was just a normal pleural line. So there's no lumpy bumpiness of that line, so probably not pneumonia. These are B lines down here, so probably more edema. Sweet. 10 correct answers, I'm impressed. All right, question 11. Nice. So that picture was of a pleural effusion. I really like that picture because the lung kind of looks like the sorting hat in Harry Potter. But it was surrounded by anechoic fluid, so that was a pleural effusion. So thoracentesis is probably indicated. DPL, these are the lungs, so you probably don't want to DPL the patient. Needle thoracostomy, that is more for pneumothorax. All right, you are on a streak, Adriana. Nice. Nice. So Z lines are not pathologic. Those are those little comet tail artifacts. Those are seen in normal lung. Not to be confused with B lines, which are pathologic, but those are the long vertical lines that extend kind of to the far field. Ooh, look at this. Got someone making their way up. Awesome. So not only was there a pleural effusion in that image, but there were fluid bronchograms. So those were the anechoic little kind of bronchioles within that image. Not to be confused with the air bronchograms, which are hyperechoic or white on ultrasound. Excellent. Nice job. So this question was just to highlight that B lines in and of themselves don't mean pulmonary edema. You have to put it in kind of the context of the patient. So in trauma, typically that is a result of pulmonary contusion instead of pulmonary edema. Ooh, we got a race now. Nice. So this one, you're looking for the barcode sign. I know it's kind of challenging to see probably since these images are so tiny, but this is a barcode in contrast to this one, which is kind of a sandy beach. You can see the little squiggles in the far field over there. Nice. Awesome. So dynamic air bronchograms are pathognomonic for pneumonia, in contrast to the static air bronchograms, which could mean atelectasis or pneumonia. But dynamic, that is pneumonia. Nice work. Adriana's holding on to it. I love it. Awesome. So A lines are those horizontal lines that are indicative of dry lung. So A lines are normal lung. So this one's false. Awesome. We're almost done. Excellent. We got a unanimous decision here. So this obviously has a bunch of B lines on it. That patient's probably going to have some trouble if you give them a bunch of fluid. All right. A few more questions. Excellent. So that was a barcode sign, meaning that patient had a pneumothorax, in which case a thoracostomy, whether a needle or a tube or a finger or whatever, is going to solve that. Thoracentesis probably would resolve the problem as well, but it's not actually the procedure that you're going to do for this. And thoracotomy would be actually like opening up the chest, more for like a pleural effusion or something like that. Or sorry, pericardial effusion. Ooh, we got a new leader. All right. This is the last question. Ready, guys? Nice. So the flaps point, that is that area in sort of the posterior inferior thorax. That is in a supine patient, is going to be the most dependent area in the lungs or in the thorax. So that's where small pleural effusions are going to accumulate first. So that's why that is the answer. All right. see who our winner is. Third place, Meow Meow. Excellent. Nice job. Nice job. All right, let me exit out of this. Do you guys have any questions for me? That's all I have. Thank you guys for participating. Excellent job, Adriana. All right, if you guys ever have questions, feel free to send me an email. I'm happy to answer anything. It was great talking to you guys.